Hello, good evening everyone. Today we'll discuss about Placenta Accreta Spectrum disorders. It is a green top guideline, so we'll discuss that. Okay. So we all know what is Placenta Previa and low-lying placenta, right? So Placenta Previa means generally normally the placental edge will be 20 mm or more from the internal os. So when there is a uterus where there is internal os, so from that place it is 20 mm away from the internal os. Okay. For pregnancies more than 16 weeks of gestation, the placenta should be reported as low-lying when the presenting placental edge is less than 20 mm from the internal os. So if the placental edge is less than 20 mm, it is not covering the os, but it is just less than 20 mm from the internal os, then it is known as low-lying placenta. If the placental edge reaches or covers the internal os on ultrasound examination, the placenta is known as placenta previa. Okay, so placenta previa in second half of the pregnancy, generally it ranges from 1 in 50 to 1 in 500 pregnancies. So in second half of the pregnancies, the placenta previa incidence is 1 in 50 to 1 in 500. So what are the different symptoms of placenta previa? So most of the patients with placenta previa, where the placenta is covering the internal os, most of the patients are asymptomatic. So for those who have complications, the most prominent symptom is vaginal bleeding. So with more than 50% of the episodes occur before 30 weeks of gestation. So 50% of the episode occurs before 36 weeks. So, okay. So the pain, there will be painless bleeding, bright red in color, can vary in amount from spotting to torrential life-threatening bleeding. The bleeding can be recurrent, could be provoked by sexual intercourse or onset of labor. And in 35% of the cases, the fetus is non-vertex presentation. Most commonly because when there is placenta previa, so the placenta will be obstructing the fetal head, and fetal head continuously move upwards, and most commonly the breech will be coming down, or it can be transverse line. So 35% of the cases, the fetus will be non-vertex presentation. So placenta previa and placenta accreta spectrum disorders. So placenta previa and accreta spectrum are associated with high maternal and neonatal morbidity, mortality also because of antepartum hemorrhage and major obstetric hemorrhage during birth and preterm birth. Rates of both placenta previa and placenta accreta spectrum have increased due to result of rising rate of cesarean birth and IVF. So the highest rate of complications for both the woman and the newborn are observed with these conditions coexist and only diagnosed during birth. Okay, so because of more cesarean sections, more IVF, this placenta previa and placenta accreta spectrum disorders are increased. So first question is, sorry. So pregnancy resulting from IVF, what are the risk factors for low-lying placenta? Resulting for IVF or endometriosis, maternal smoking, adenomyosis, previous cesarean section, which is not a risk factor. So adenomyosis is not a risk factor. Others are all risk factors. So IVF is a risk factor, history of endometriosis is a risk factor, smoking, previous cesarean is a risk factor. So if you say these are different risk factors, okay, so which we already learned, that previous to cesarean birth, multiple pregnancy, IVF, endometriosis, maternal smoking, fibroid, okay. In fact, till endometriosis, it is 2+ evidence. So previous cesarean section, multiple pregnancy, IVF, endometriosis is 2+ evidence. Uterine fibroid, smoking, short pregnancy interval, advanced maternal age, this thing. So what is the relative risk of placenta previa? If there is a history of one cesarean section, then the risk of placenta previa is 4.5, 4.5. 2 cesarean section, that is 7.4. 3 cesarean section, then 6.5. Okay, 4 cesarean section, it is 40%. So remember this, 4 for 4. So if there are 4 cesarean section, there are 44% chance that this pregnancy she might have placenta previa. Remember this placenta previa, this percentages are for placenta previa. Okay, so 4 cesarean sections, 44%, and 1 cesarean section, 4%. Okay, so 1, 2, 3, 4. 1 cesarean section, 4%, 4 cesarean section, 44%, 2 is almost 7.4%, and 3 is 6.5%. Okay. How to diagnose a low-lying placenta or placenta previa? How to diagnose and what to do? What kind of care should be given? So low-lying placenta means which is less than 2 cm from the internal os, or placenta previa that is covering the internal os. On transabdominal ultrasound scan, if we see at 18 to 20 plus 6 weeks, then you'll consider, first step you'll consider to do transvaginal ultrasound. Okay. Transvaginal ultrasound is done to confirm the diagnosis and also to see whether placenta is mainly posterior or not. Why? Because posterior placenta previa or low-lying placenta are dangerous compared to anterior. And if there is high BMI, if the patient is having high BMI, you should go for transvaginal ultrasound. Anomaly screening at 18 to 20 plus 6 weeks gestation should include placental localization. Placenta previa, if the presenting edge reaches or covers partially or completely the internal os, is known as placenta previa. Low lying is less than 20 mm. A follow-up ultrasound scan should be done. Between mid gestation and 37 weeks, over 90% of the placenta are recorded as low lying. See, almost mid gestation to 37 weeks, almost 90% are recorded as placenta previa. So almost third trimester growth scan is very important to find out the placental location as well. So TVS, that is transvaginal ultrasound scan, is very important, and transvaginal ultrasound is more accurate than transabdominal to differentiate the low-lying and placenta previa. And almost see, if you did transabdominal, how much percentage that the diagnosis can be changed with transvaginal is 60%. Okay, remember these percentages. Okay, 60%. Now once again I'll revise that cesarean sections with placenta previa. One cesarean section, then 4%. 4 cesarean section, then it is 44%. 2 cesarean section, it is 7.4%. And 3 cesarean section, it is 6.5%. Okay, remember this 1 and 4 mainly. Another percentage which I told is transvaginal ultrasound can reclassify placental previa diagnosis is 60% chance. Okay. Women with symptomatic low-lying placenta or placenta previa should be provided antenatal care like hospitalization, individual clinical need, social circumstances like distance between the home and hospital, transportation and all. Women should be informed of the risk associated with the low-lying placenta, like the bleeding risk, when to go for emergency, contact numbers and all. Women with asymptomatic placenta previa confirmed at 32 weeks, follow-up scan should be done for outpatient but should be encouraged to ensure that they have safety measures in the place and access to help at home and ready to access to the hospital. So how to prevent preterm birth? So tocolysis can be given if a patient with placenta previa came, symptomatic placenta previa came. So you can give tocolysis for 48 hours only to cover the steroid dose. Okay, then you should deliver her. Routine cyclage is not recommended. Corticosteroids should be offered between 24 to 34 weeks. Remember this 4. Okay, so 24 weeks onwards you'll give corticosteroids. Up to 30 weeks of gestation, you'll give magnesium sulfate in whom preterm birth is anticipated. So benefit of corticosteroid after 35 weeks, it should be discussed. If the woman is saying that give me corticosteroids, then you should discuss with the woman and you can prescribe. But generally till 34 weeks, you should go for corticosteroids. Birth in case of low-lying placenta or placenta previa is you should go for birth by 37 weeks, 6 days. 37 weeks, 6 days. Remember this also, 6 days, because they will give 37 weeks, 4 days, 37 weeks, 5 days in that way. So 37 weeks, 6 days is option. If she is asymptomatic, then you can go till 37 weeks, 6 days. Trail of labor should be discussed who have third trimester asymptomatic low-lying placenta previa. Should be discussed like low-lying placenta, low-lying placenta is there, then you can discuss the trail of labor. But placenta previa, you should go for cesarean section. And low-lying placenta can be delivered vaginally. Almost 80% of vaginal successful vaginal birth are seen. So placenta previa is there, then you should plan because there is interruptive hemorrhage, PPH, hysterectomy, birth also, even baby resuscitation should be done. On-site blood transfusion services should be done. Should be present. You should check these things. Okay. Pre-operatively, you should optimize the hemoglobin level. Okay. Senior obstetrician should be discussed. The case should be discussed with senior obstetrician. Then If the patient declines blood products, then high risk of maternal mortality should be explained. Okay, intraoperative hemorrhage, mainly in particular placenta is anterior, may require additional surgical procedures, because while doing cesarean section, if the placenta is anterior, then that patient can land in emergency hysterectomy. Women with atypical red cell antibodies form particularly high risk group and should be involved local hematology and blood transfusion services. In case planned cesarean birth for placenta previa, a senior obstetrician and senior anesthetist should be present. Fetal malpresentations are also present. I told you, like breech presentation can be present. So you should maintain in your mind that how to deliver the breech. Same thing. So there is a high risk of hemorrhage. Mode of anesthesia should be discussed. Um, like regional anesthesia you can do, but facilities should be present to convert into general anesthesia, and we should also take consent from the patient for general anesthesia. Uh, Intraoperative self-salvage is beneficial for the patients, particularly who decline the transfusion of blood products. Okay. Coming to procedures, like while giving uterine incision, you will transect through the placenta. You'll immediately clamp the umbilical cord. Delayed cord clamping should be avoided. Okay. Uterotonic tranexamic acid, if they fail to control, then you go for balloon tampon, compression sutures and all. Early recourse of hysterectomy, if condition medical surgical conditions failed, then you should go for hysterectomy. So what is the success rate of balloon in controlling BPH? It is almost 80%. Okay, so success rate is 80%. Live cesarean, this is very important topic. Like if there is a cesarean scar pregnancy, like previous cesarean scar, and there is cesarean scar pregnancy early weeks, and if we continue that pregnancy, there is high risk that that patient may land in placenta accreta. Okay, so if there is a history of cesarean birth and now the pregnancy cesarean scar pregnancy, then early pregnancy scan should be done and should manage. Okay, women diagnosed with the cesarean scar pregnancy, they should go for expert consultant, because there is major complications risk like placenta previa, accreta in second and third trimester. Depends upon number of previous cesarean births. Okay, and retroverted uterus also may land up in cesarean scar. So approximately 2/3 of the cesarean scar pregnancy fail before the end of first trimester. But if they continue then second and third trimester, then there can be results in placenta previa, accreta. Very rarely uterine rupture can occur. So placenta previa, how to do cesarean birth? There it should be regional anesthesia is safe. Okay. And at the placenta, if there is anterior, then high risk of bleeding is there. So general anesthesia should be considered. Fenestrial lower uterine segment incision, vertical incision in case of malpresentation, JSF incision can be given. Okay. Anterior placenta aim to go around, require incision. Cord clamping transected, then immediate cord clamping. Early recourse to hysterectomy is recommended if medical and surgical intervention for massive hemorrhage prove ineffective. So this is a flow chart. So if there is no previous history of cesarean delivery or uterine surgery, then ultrasound is done. Generally including TVS you'll do. Okay. And the 28 to 30 weeks you'll do. And if it is low lying placenta, follow-up ultrasounds are done. If it is asymptomatic, you'll go for again transition ultrasound. If low lying or asymptomatic also, you go for transition ultrasound. If the placental edge is more than 2 centimeters, no further examination is there. See, this is important. If the placental edge is more than 2 centimeters, there is no need of further ultrasounds. Okay. If previous history of one or more cesarean section, ultrasound suspecting past placenta accreta spectrum, then you refer her to placenta accreta spectrum center. This is the same thing which I told. So spectrum is, see, accreta, increta, collected. Accreta means it does attach the myometrium. Increta means it invades the myometrial layers. Percreta is the chorionic villi penetrate up to the serosa, sometimes involving the bladder, intestine, parametrium, other neighboring tissues. So if you see, this is a risk factor for evidence for PAS. Okay. First I told placenta previa. Now I am telling about PAS. So first thing, coming to risk factors, previous cesarean section, anterior low lying placenta. Okay. uterine surgery, trauma, placenta resulting from IVF, pregnancy resulting from IVF. If PAS is diagnosed, how many cesarean sections the PAS is diagnosed, that is important. Okay. And placenta previa with prior cesarean section, this is the thing. So, okay. So, if there is a previous cesarean section and now she came with second pregnancy and on the scan there is placenta previa, this placenta previa becoming PAS, how much percentage? First I told that 1, 2, 3, 4, which I told, that is incidence of placenta previa. Now the placenta previa already confirmed, already 4% placenta previa confirmed. Now this turning into accreta is how much? They'll ask this. Okay. So this is 1 cesarean section, it is 3%, 2 cesarean sections, it is 11%, 3 cesarean section, it is 40%, 4 cesarean section, it is 60%, 61% in fact, and 5 cesarean section or more, it is 67%. Okay, very important thing is this one. 3 previous cesarean section, placenta previa converting into placenta accreta is how much percentage? This is very important question. Okay, it is 40%. How much? It is 40%. So 3 cesarean section, it is 40%. So again, I'm repeating. 1, 2, 3, 4. If 1 cesarean section, placenta previa incidence is 4%, and that placenta previa converting into placenta accreta spectrum is 3%. Okay. So 2 cesarean section 11%, 3 cesarean section 40% important, 4 cesarean section 61%, 5 cesarean section or more, it is 67%. Okay. So 18 to 20 plus 6 weeks, you'll go for placental localization scan. High probability scan is done. And previous cesarean section multidisciplinary team should be involving. Specialist center should be there. And these are the ultrasound imaging findings to find out whether it is accurate or not. If you're having a doubt, okay, that is loss of clear zone. There will be loss of clear zone. Myometrium will be thin. Bladder wall, the bladder wall will be there in the placenta, and you have bladder wall. There will be thinning of the bladder wall. Placental bulge, exophytic mass. These features are present. Then you'll refer her to PAS center. TVS is available, you go for that. MRI is not recommended in routine. MRI is not recommended routine antenatal evaluation. Okay. Commonly used PAS visually assessed in 2 non-placental areas you should see, that is uteroplacental interface and myometrium. Ultrasound imaging signs and all should be, which I already told. Then MRI in diagnosing placenta accreta is 75 to 100% sensitivity and 65 to 100% specificity. These are MRI features, which I told earlier is ultrasound feature. MRI features are, you can see abnormal uterine bulging abnormally, dark interplacental bands, heterogeneous signal intensity seen. So whenever they ask you about MRI features, you should say dark bands, intensity, signal, these things. Ultrasound features are different. There is no signal. Okay. And vasculature of the placenta is disorganized. Uteroplacental zone is disrupted. And sagittal view, you can see placenta accreta. Women identified locally has high probability of placenta accreta at birth should be assessed nearest. See, if you are feeling that she might have accreta, then you should refer her to specialized center. If on opening only, if you're on opening, you can find that she is accreta, then you can close her and you can refer her. Okay. Timing of birth and use of corticosteroids should be tailored, and after 35 weeks, giving corticosteroids is individualized. High probability of PAS at birth. And baby blood product should be available. Baby also should go for an ICU. Even adult can land into ICU, so these should be present. Then high probability of PAS at birth, giving consent for cesarean section. We should also take for high risk of blood transfusion, lower urinary tract damage, hysterectomy also consent you should take. If they're having any religious belief, then you should go for cell salvage method. In case of placenta previa and previous cesarean section, the risk of cesarean hysterectomy is very important. So if a lady, She had a history of previous one cesarean section, and now she has placenta previa. So risk of cesarean hysterectomy they will ask. It is 27 in 100. How much? It is 27 in 100. So you should explain them. See, now we are having placenta previa. We'll do cesarean section. It's okay, but you may land in cesarean hysterectomy in 27 in 100. Choice of anesthetic procedure should be discussed with the woman. Then general anesthesia can be given. Conversion is above 50% conversion is in. Then you have attempting to separate the placenta from the uterine wall or incising the placenta to give birth to the baby should be avoided. Generally, you should go see incision. You can have the margin of placenta, so incision should be given above, and you deliver the baby above from above. Okay. Abnormally on damage to the abnormal attached area and pass can lead to uncontrollable pelvic bleeding, and mother can die. Hemodynamic parameters can deteriorate, and hypovolemic shock can occur. Where possible, uterus preserving surgical techniques should be involved. There is no evidence to support the routine use of prophylactic ureteric stents should not be used routinely. However, collaboration with urological surgeon, if they're available, it is very important. Okay. Major uterine remodeling, thick adhesions between uterine and bladder cirrhosis are associated with high risk of UTI damage. Okay, primary hysterectomy following birth of the fetus through hysterotomy above the placental site implantation site can be done, and birth of the fetus through hysterotomy above the abnormal implantation area followed by partial excision of excreta area can be done. See, sometimes you can find excreta is there, you will deliver the baby, and at that area excreta wherever it is there, you will partially do, and chunk you will leave it inside. You can do that. And you will write in the notes that we did partial excision of excreta area and repair is done. Okay, so birth of the fetus without disturbing the placenta should be done, and placenta can be left in situ sometimes, followed by planned cesarean hysterectomy 3 to 7 days later. This also can be done. I think this is known as interval management. Okay, birth of the fetus through the incision above the placental implantation site, leaving the placenta in situ, followed by expectant management can also be done. Without hysterectomy, you can go for expectant management. Interventional radiology procedure has little evidence. Some says that go for arterial, reported post-operative complication of arterial thrombosis is seen in many external iliac and femoral arteries. Okay, you can go for endovascular balloon occlusion of the aorta can be used with PAS who decline donor blood transfusion to decrease the blood loss. Okay. Various combinations have been proposed, including intraoperative iliac artery and iliac artery and/or postoperative uterine artery embolization, and immediate preoperative insertion of internal iliac artery or abdominal balloon for intraoperative occlusion. So this you're doing for resuscitative. So this is known as REBOA, that is resuscitative endovascular occlusion of aorta. You understand? So you will occlude the aorta. Basically abdominal balloon for intraoperative occlusion, then again you remove it. Okay. Laparotomy should be done. Then now first you'll absorb the vascularization and all. Then you'll proceed with the procedure. Leaving the entire placenta in situ after delivery of the fetus can be considered. If it depends on individual choice. Okay, and when placenta is left in situ, local arrangements need to be made to ensure regular review. Like if you are left the placenta in situ, you go for ultrasound examination post-operatively. Okay, and patient should not bleed. Patient should not bleed. If you are leaving placenta in situ, patient should not bleed. Okay. Placenta conservative management is done. Like the risk of chronic bleeding, sepsis, septic shock, peritonitis, uterine necrosis, fistula, edema, acute renal failure, this can be seen. Methotrexate should not be used for expected management. Then woman and her partner to be involved in preoperative decision concerning the mode of anesthesia and all, they should be discussed with that. And women with placenta accreta spectrum can be managed conservatively as well. So some of the question is, so on artificial rupture of membrane, the lighter was clear. Oxygen infusion was commenced. Epidural cited. 3 hours later, she complained of severe sudden constant pain. So basically there is pain. And previously there is a reassuring CTG. Now it's showing atypical deceleration with slow recovery, and FHR is difficult to pick. On vaginal examination, it is 5 centimeter. Vertex is not in the pelvis, and like it is blood stain. So there is some sort of antepartum hemorrhage, and fetal heart rate is not reassuring. So you should go for grade 1 cesarean hysterectomy. Grade 1 is cesarean hysterectomy. Then 39 years primary, present with history of painless bleeding at 31 weeks 6 days. This is the first episode of bleeding during this pregnancy. At home, the blood choked through her clothes and ran under her legs, down her legs, then filled 2 sanitary towels. By the time she arrives at the hospital, the bleeding seems to be settling. On 20-week scan, placenta previa. Ultrasound appointment 4 times a day. So, pulse okay, BP okay, respiratory okay, temperature okay, saturation good. CTG also reassuring. What to do? So basically, she is 31 weeks and she had a history of bleeding. So you should go for 31 weeks. So you should go for cross matching, admit for observation, steroids. We will also review 28 weeks, 28 years primary. She's 32 weeks. She's having heavy bleeding. Okay, around 2 liters of blood was lost, and immediate blood transfusion has been started, and it is bleeding from the venipuncture site. So wherever you're puncturing, it is bleeding. So she's landed up in DIC. So you will go for FFP and cryoprecipitate. 32 years, Jehovah Witness, 34 weeks pregnant, 1 previous cesarean. Ultrasound shows 1.5 centimeter low-lying placenta with irregular retroplacental sonolucent zone abnormal placental acunate. That means it is accreta. Color Doppler hypervascularity between bladder and serosa. So it is basically it is Placenta Accreta Spectrum. Okay, she's 34 weeks. She's 34 weeks, na? So and ultrasound also showing that some sort of this thing. So you go for TVS, MRA, refer to unit, cross match 4 units of blood, admit for observation, consent for hysterectomy, autologous blood transfusion, electric section, discuss with hematologist and blood bank. So you go for MRA. Okay. So she is a known placenta previa, minimal bleeding and pregnancy and abdominal operation. The fetal head is now engaged. So as fetal head is engaged, it is not placenta previa. Maybe placenta has migrated up. Okay. So for this station, you'll go for confirmation of placental localization by transition ultrasound. Ultrasound at 28 weeks gestation has been found low lying. Now presence with painless bleeding. Suspected succinate lobe with blood vessels and the main placenta course over the fetal membrane. So it is Vaxa previa type 2. Ultrasound 29 years, IVF 28 weeks gestation is approximately 25 mm from the interloss. Twin pregnancy 28 weeks, approximately 25 mm. So it is normal placenta, na? Normally sighted placenta. So ultrasound at 18 weeks placenta is described as anterior and covering the interloss asymmetrically. Covering the interloss, that is placenta previa. Primary 32 weeks, vaginal bleed 150 ml, uterus tense, difficult to palpate, symphysis fundal height is 36. So vaginal bleeding is there. Transverse size and intrauterine depth. So you'll resuscitate her and cesarean section is done. Primary uterus tense, difficult to palpate, BP okay. Ultrasound confirms fetus is dead. Ultrasound confirms fetus is dead and she's having vaginal bleeding. Okay. In this also, even the fetus is dead, then you'll go for resuscitation and the immediate cesarean section. If symphysis fundal height is 36 centimeter, even though she's 32. Okay. You go for cesarean section. 41 weeks, first baby normal delivery, second baby elective cesarean for breech. Initial glimpse cervix 2 centimeter, ARM clear, oxytocin epidural sited. 3 hours later she complains of sudden severe pain. Same which we already read, grade 1 cesarean section. Okay, that's it. Thank you. Or if the ultrasound shows fetus is live with the same thing, if the lower lying placenta, if the fetus is live and head is engaged, then you can go for normal delivery. Yes. Okay. So, any doubts, please ask me. Thank you.